All right, so this PowerPoint, we are going to be covering medication for mental disorders. According to this medical model, the afflicted person appears with a set of symptoms, and on the basis of these symptoms, a diagnosis is made as to which disease the patient is suffering from. Once the disease is known, its cause can be determined, and then the patient provided with a cure. For mental disorders, a set of behavioral symptoms is about all one has to define and diagnose the disorder. A person might be inactive, they might not sleep or eat well, they don't say as much, um, and what little is said might be quite negative. The behaviors that are referred to as indicating depression are varied and probably have many different causes, many of which are not known to them. Despite the criticisms of this model, it still seems to guide much of the current thinking about mental disorders. The fact that psychoactive drugs can be effective in controlling symptoms, if not in curing disorders, has lent strength to supporters of the medical model. Although a lot of people have searched for many years, there is no direct evidence for a chemical imbalance causing depression or schizophrenia or anxiety disorders. And although drug therapy is the first line treatment for most mental disorders, there isn't a clear biological understanding of how the drug works to reduce the symptoms of these disorders. In 2013, the American Psychiatric Association published the fifth edition of its Diagnostic and Statistical Manual of Mental Disorders, referred to as the DSM-5. This manual provides criteria for classifying mental disorders into hundreds of specific diagnostic categories. With anxiety, anxiety is a normal and common human experience. Anticipation of potential threats and dangers often helps people avoid them. However, when these worries become unrealistic, resulting in chronic uneasiness, fear of impending doom, bouts or terror or panic, they can interfere with the individual's daily life. And so the DSM-5 refers to these and other problems as anxiety disorder. And so we would also classify specific phobias, social anxiety disorder, panic disorder, agoraphobia, and generalized anxiety, all underneath anxiety disorders in the DSM-5. Psychosis refers to a major disturbance of normal intellectual and social functioning in which there's a loss of contact with reality. A person suffering from a chronic or long-lasting psychotic condition for which there is no known cause will probably receive the diagnosis of schizophrenia. Depressive disorders are characterized by feelings of sadness, emptiness, irritability. This can be accompanied by body and mental images that impairs the individual's ability to function. And there's different criteria that has to be met. And so that's why you see duration of at least 6 months. So with every classification in the DSM-5, there's a checklist. And, one of the things that we look for is how long has a person, had these problems or situations that they're dealing with, the characteristics of the disorder. And so most of them, at least 6 months, some might be a month, 2 months, a year. It varies for each one. Bipolar and related disorders, on the other hand, must involve at least one manic episode, and perhaps this would be with alternating periods of depression. And so with bipolar disorder, you might be manic for a few days or a few weeks at a time, or maybe a few months at a time, and then you're depressed for a week, and then you're manic, and then you're depressed for a month, and then you're manic. And there's no rhyme or reason as to how quickly you cycle through the mania and the depression. It varies with each person and each situation. Looking at treatment of mental disorders, this would be before 1950. The focus, because the focus is on drug therapy, a good place to even go back farther to is 1917, when a physical treatment was first demonstrated to be effective in serious mental disease. In those days, a great proportion of psychotic patients with psychosis were suffering from a general paresis. This is an infection of the nervous system. It was noted that the fever associated with malaria often produced marked improvement, and so in 1917 we have malaria therapy, which was introduced. Uh, and so that was the treatment for it. In the 1940s, this particular type of treatment was virtually eliminated when the antibiotic penicillin, which could cure syphilis, became widely available. In the 1920s, wealthier patients could afford a course of narcosis therapy in which barbiturates and other depressants were used to induce sleep for as long as a week or more. Another use for the sedative drugs was in conjunction with psychotherapy and an intravenous dose of um, the thiopentyl sodium, which would relax a person and produce more talking in therapy. And this is where the idea of the truth serum came out. In the 1930s, European physicians experimented with various chemicals to induce either a coma, insulin, or convulsions similar to epilepsy. At first, this type of treatment was used in schizophrenia, and patients were calmer for at least a short while, or a short period of time after the seizures were over. However, repeated treatments were problematic as the patients became quite agitated in the few minutes after the drug was administered and before the seizures began. So in 1938, it was demonstrated that seizures could be induced by sending electrical current through the brain of a patient who was under anesthesia. ECT is where we move to next, the electroconvulsive therapy. This replaced drug-induced seizures and came to be in widespread use in mental hospitals until the 1960s. While there proved to be no long-term benefits for schizophrenia, ECT turned out to be a rapid and effective way to reduce symptoms of depression. ECT is still used to treat severely depressed patients who do not respond to medication. And by the 1950s, probably the major drug in use for severely disturbed patients in large hospitals was to give them paralleldehyde, which is a sedative. So looking at the antipsychotics, we had a number of people that were involved in the discovery of these antipsychotics, and they had special properties when used with mental patients. And so the neuroleptic meaning taking hold of the nervous system, which is a term implying an increased amount of control. Although both of these uh, terms or antipsychotics are still in use today, most medical texts now refer to this group of drugs as antipsychotics, reflecting their ability to reduce psychotic symptoms while producing less drowsiness and sedation than some of the earlier drugs. In the years since 1950, there's many new drugs that were introduced and several completely new types of antipsychotic drugs that have been discovered. Now, antipsychotic drugs are referred to as either being conventional antipsychotics or atypical antipsychotics. The atypical antipsychotics now dominate the market, with 4 of these drugs among the top 25 in psychiatric medication prescription sales in 2018. The first clue to the mechanism of action for antipsychotics was that virtually all of the drugs and other conventional antipsychotics produce pseudo-Parkinsonism, and patients treated with these medications exhibit symptoms similar to Parkinson's disease, which is the tremors and muscular rigidity. Because Parkinson's disease is known to be caused by a loss of dopamine neurons in the dopamine pathways, scientists focused on the ability of antipsychotic drugs to block dopamine receptors. So it's now well accepted that the initial effect of antipsychotic drugs to block the D2 dopamine receptors. However, this effect occurs within the first dose, but the antipsychotic effect of these drugs is not seen for at least 10 to 14 days, which is known as the lag period, LAG lag. So the ultimate mechanism of antipsychotic action is some response of the nervous system to be repeated administration of dopamine antagonists. And clozapine, yeah, we'll talk about that on this slide too. When clozapine was first introduced, it differed from the other antipsychotics in two interesting ways. First, it produced much less of the pseudo-Parkinsonism than the other drugs. And second, some patients who failed to improve with other antipsychotics showed improvement when treated with clozapine. Clozapine produces effects on a wide range of receptor types, but eventually it was determined that its unique properties were probably related to its ability to block both D2 dopamine and then the 5-HT2A serotonin receptors. The atypical antipsychotics are sometimes referred to as a serotonin dopamine antagonists, and the pseudo-Parkinsonism is reduced because of serotonin dopamine interactions in the neogastrial pathway. Allergic reactions might be noticed, such as jaundice or skin rashes. Some patients exhibit photosensitivity, which is a tendency for the skin to darken and burn easily in sunlight. These reactions have a low incidence and usually decrease or disappear with a reduction in doses of low white blood cell count. Um, and this can develop in the early stages of treatment. So this one is the most serious complication of the antipsychotic drug. And so it means late appearing abnormal movements and refers primarily to rhythmic, repetitive sucking and smacking movements of the lips, thrusting of the tongue in and out like fly catching, and movements of the arms, toes, or fingers. The elderly patients have been treated with antipsychotic drugs for years, often to control behavioral problems such as emotional outbursts or inappropriate sexual acting out in institutionalized patients. In many cases, these patients are suffering from dementia, and their uncontrolled behavior is a problem for their families, staff, other patients. Evidence of a significant increase in death risk from cardiovascular and other problems in elderly patients treated with atypical antipsychotics led the FDA in 2008 to require a black box warning regarding the use of these drugs for behavior management in elderly patients with dementia. In 1951, ipranazide was synthesized in the search for the new anti-tuberculosis drugs. At the time, tuberculosis was a major public health problem and caused tens of thousands of deaths each year in the United States. So this proved to be just an effective tuberculosis treatment, but also a mood enhancer in some tuberculosis patients. And so this is an MAO inhibitor, and its discovery opened up a new class of compounds for investigation. Because aged cheeses are one source of triamine, this is often referred to as the cheese reaction. So a severe headache, palpitations, flushing of the skin, nausea, vomiting are some of the symptoms of this reaction, which have in some cases ended in death from a stroke. Besides avoiding foods and beverages that contain um, triamine, like aged cheeses, Chianti wine, smoked or pickled fish, patients taking MAO inhibitors must also avoid um, other drugs such as amphetamines, ephedrine. MAO is an enzyme involved in the breakdown of serotonin, norepinephrine, and dopamine, and its inhibition results in an increased availability of these neurotransmitters at the synapse. The tricyclic antidepressants were found in a search for better antipsychotics. The drug had little effect on psychotic symptoms, but it improved the mood of depressed patients. The first tricyclics were discovered to interfere with the reuptake into the terminal of the neurotransmitters norepinephrine, dopamine, and serotonin. And so this results in an increased availability of these neurotransmitters at the synapse. Because MAO inhibition also results in increased availability of the same neurotransmitters, there's been considerable speculation that the antidepressant actions of both classes of drugs resulted from increased synaptic availability of one or more of the neurotransmitters. And then we have fluoxetine or Prozac, which in 1987 uh, began the SSRIs. Prozac is safer than the tricyclic antidepressants in that it is less likely to lead to overdose deaths. So physicians felt more confident about prescribing it. Prozac is safer than the antidepressants, the tricyclic antidepressants, since the overdose has been dropped. The likelihood of overdosing has been dropped. Drugs have also been developed that are the reuptake inhibitors for both serotonin and norepinephrine. In that sense, they are similar to the old tricyclics, but the newer drugs are more selective. So they have fewer actions than the tricyclics and are referred to as selective serotonin and norepinephrine reuptake inhibitors. So an effective but controversial treatment for depression is electroconvulsive shock therapy, ECT. One factor that makes ECT sometimes the treatment of choice is its more rapid effect than found with current antidepressant drugs. Reversal of depression might not occur for 2 or 3 weeks with drug treatment, but with ECT, results sometimes are noticed almost immediately. When there's a high risk of suicide, ECT is often considered necessary, and it is possible to use both drug and ECT simultaneously. In the late 1940s, two medical uses were proposed for salts of the element lithium. In the United States, lithium chloride, which tastes much like sodium chloride or table salt, was introduced as a salt substitute for heart patients. Three factors slowed the acceptance of lithium in the United States. First was the salt substitute poisonings, which gave lithium a bad reputation as a potentially lethal drug. Second, mania was not seen as a major medical problem in the U.S. And the third and possibly most important factor is economic and relates to the way the new drugs are introduced into the U.S. by companies that hope to make a profit on them. After several years of frustration, the weight of the academically conducted research and the clinical experience in Europe was that several companies received approval to sell lithium in 1970. And so lithium is both safe and toxic. It's safe because the blood level can be monitored routinely and the dose adjusted to ensure therapeutic, but not excessive blood levels. Of primary importance in the therapeutic use of lithium is the realization that lithium acts as a mood normalizing agent in individuals with bipolar disorder. Lithium will prevent both manic and depressed mood swings. It has only moderate effects on a unipolar depression. In addition to lithium, some drugs were initially developed as anticonvulsants. Valproic acid, the carbamazepine, and the lamotrigine may be particularly useful in people who might be susceptible to epileptic seizures. Some atypical antipsychotics are also used as mood stabilizers to treat bipolar disorder. The mood stabilizing anticonvulsants and antipsychotics are thought to be better accepted by patients than is lithium, but noncompliance is an issue with these drugs as well, but maybe perhaps not as much with lithium. The use of modern psychopharmaceuticals, which began in the 1950s in the US, has affected the lives of millions of Americans who's been treated with them. The year in which the clorazepam was introduced in the United States, 1955, was the last year in which the population of these hospitals increased. Since then, the average population has continued to decline. The antipsychotics do not cure schizophrenia or other forms of psychosis, but they can control the symptom to a great degree, allowing patients to leave the hospital, live at home, and earn a living. The movement out of mental hospitals was accelerated by the 1963 Community Mental Health Act, which provided federal support to states to develop community-based mental health centers. The idea was to treat mental patients closer to home in a more natural environment at a lesser expense and on an outpatient basis. The majority of psychiatrists in practice today spend less time doing psychotherapy than did their colleagues in the 50s. In fact, many psychiatrists, the first issue is to establish an appropriate drug regimen and only after the initial symptoms are controlled will they engage in talk therapy. Along with liberation of patients from hospitals and their return to the community came a concern for their civil rights. Indefinite commitment to a hospital was declared unconstitutional in 1975, and all states have since developed procedures to protect the rights of individual patients. A periodic review of the patient's status are called for, and if at any time the immediate danger is not present, then they must be released. A patient who is dangerously psychotic might be admitted for treatment, and after a few weeks on the antipsychotic drug might be sufficiently in control and allowed to leave. Perhaps patients might be released into the community that are functioning with medication, or if they're too sick to really take care of themselves, but not sick enough to present an immediate danger, that becomes problematic as to how we help them or what we do for them. We have more mentally ill persons that are jailed each year than we have that are admitted to state hospitals. And this is a large part of our homeless population suffer with some type of mental illness. So that's definitely something that we need to improve and create more programs on, especially here in the United States. And the eventual result in violation of law, can lead to imprisonment, but about 1/3 of homeless people in the U.S. have some form of serious mental illness. And that wraps us up for today. Uh, Thank you for listening, and looking forward to posting more.